Hello, and welcome to the AC Forum webinar today. Our title is Update on Andexanet Alpha for Reversal of Factor Xa Inhibitors, the Annexa-I trial. With us today, we have a special guest speaker, Ashkan Shoamanesh, who will be presenting the results of the Annexa-I trial. He was involved in running that trial. You'll have me, Jean Connors, a hematologist in Boston, and Jori May, a hematologist at UAB, moderating. And we have two expert panelists to discuss during the Q&A, Dr. Deb Siegal from University of Ottawa, another hematologist, and Dr. Jerrold Levy, professor of anesthesiology at Duke University. Now I'm going to turn this over to Ashkan. And the platform's yours.
Well, thanks very much for that kind introduction, Jean, and hello, everyone. Good morning, good afternoon, evening, wherever you are in the world. So I'm pleased to be presenting to you an update on Andexanet Alpha for the reversal of intracranial hemorrhage, and in particular, focusing on the Annexa-I trial results on behalf of Stuart Connolly, my colleague, and the Annexa-I investigators. These are my disclosures, the most relevant one being that I've worked in both a research and consulting capacity with AstraZeneca. So as, of course, we're all aware, direct-acting oral anticoagulants are being used more frequently on the basis of, one, an aging population that's getting increasing indications for these medications, as well as their favorable safety profile relative to traditional vitamin K antagonism. On the left, you'll see DOAC utilization trends from Medicare Part D beneficiaries, demonstrating an exponential growth over the past decade. And not surprisingly, although there is less rates of intracranial hemorrhage with these agents relative to vitamin K, they still do occur. And there's, of course, bleeding elsewhere in the body as well, including GI bleeds. And we're seeing an increase in DOAC or factor Xa associated bleeds, in particular. In the figure on the right, we're demonstrating the increase over time that corresponds to the increased use of these medications. And about 10% of these major bleeds occur intracranially. Now, the reasons why direct-acting oral anticoagulants have less intracranial hemorrhage relative to traditional vitamin K antagonists is uncertain. But one hypothesis is that, as opposed to knocking out all vitamin K-dependent factors and getting a broad anticoagulant response by direct kind of one-to-one stoichiometric inhibition of either factor Xa or factor IIa, this allows the coagulation cascade to mount a response that could overwhelm these medications and still maintain hemostasis if someone were to have a small bleed, and hence they don't get large enough to present with a symptomatic hemorrhage. That's one of the hypotheses. And based on that, some people have questioned, well, are the bleeds that are occurring on these agents, not only are these agents reducing the incidence of intracranial hemorrhage, but perhaps are the intracranial hemorrhage that occur on these agents smaller and less disabling than those that are occurring on vitamin K antagonists? And there is some evidence in that regard. And this is an individual participant data meta-analysis by Georgios Siboulis, one of our colleagues in Greece, that looked at multiple observational cohort registries, comparing baseline and repeat CT scan features of bleeds occurring in the intracranial bleeds occurring on direct-acting oral anticoagulants versus warfarin. And what you'll notice is that indeed there is a suggestion that their presenting disability or severity quantified by the NIH stroke scale is less. So 7 in those that occur on DOACs versus 13 in those that are occurring on warfarin. And this corresponds to actually smaller ICH volumes, so roughly 13 cc's in those occurring on DOACs versus 23 cc's in those occurring on warfarin. However, the rates of hematoma expansion or further growth within 24 hours is the exact same at about 40% on vitamin K antagonists or DOACs, and overall mortality is the same as well, about 25% in each arm of this, either on vitamin K or NOACs. And this mortality figure of about 25% is pretty consistent in the observational data, and actually even less when you look at the mortality in those that had intracranial hemorrhages, for instance, in the original Aristotle trial that tested apixaban in patients with AF, or Rocket AF that did the same. With rivaroxaban, it was actually closer to 50%. And what this data suggests is that there may be even a greater window of opportunity with DOAC-related bleeds because, and factor Xa inhibitor-related bleeds, they're coming in at a lower degree of severity, smaller ICH volumes, but ultimately they have high rates, the same rates of expansion, and similarly poor outcomes as vitamin K antagonist-related bleeds. So if we're able to freeze them in that initial lower severity presentation, we could even have a greater effect on their long-term outcomes relative to vitamin K antagonists when by the time they're presenting, they're already larger and more disabled. And hematoma growth is really kind of the holy grail of most acute ICH treatments that are being tested because it has very strong correlations with poor clinical outcome. For every 1 cc increase in ICH growth, you're 6% more likely to increase 1 point on a modified Rankin scale, which is a scale of stroke-related disability that's shown at the bottom of the slide. If you have a 10% proportional increase in ICH volume, you're 16% more likely to grow 1 point on the scale. If you have a proportional 33% or greater growth, you have the positive predictive value to have a poor outcome quantified by an MRS of 4 to 6 at 90 days is 70%. And MRS of 4 to 6 is either not being able to ambulate without the assistance of another human and being dependent on others for activities of daily living, being severely disabled and bedridden or dead. And then for an absolute cutoff of 12.5 cc's growth or greater is an 80% positive predictive value to have an MRS of 4 to 6 at 90 days. And why is that? Well, I'll show you an example of actually a case that I saw many years ago during my training, which was actually while we were still using even FFP for warfarin-related bleeds. And this is a 77-year-old man who presented with a 3 cc bleed. Their ICH score at that point, which is a prognostic score that we use to look at or predict the prognosis of death in patients with ICH, was 0 when they presented, and that translated to 0% mortality at the time. They were provided with FFP and vitamin K, and their INR, which was initially 3.2, did not normalize for another 5 hours, which I'll show you the ship has sailed if you're reversing anticoagulation any longer at this time point after presentation. And this is going to be relevant when we think about how effective will PCC actually be in mitigating hematoma growth in patients presenting with intracranial hemorrhage. They basically deteriorate clinically. A repeat CT scan several hours later showed a 42 cc bleed now, which had ruptured into the ventricle. And their ICH score was now 3, predicting a 72% chance of mortality, and unfortunately, this patient did indeed pass away. And time, or the paradigm of time is brain that we really adhere to quite strongly in ischemic stroke equally applies to ICH when you're trying to mitigate hematoma growth. Because as you can see by this figure, which comes from an IPDMA or individual participant data meta-analysis of several other observational cohort studies, is that there's really an exponential relationship between earlier time from symptom onset to scan and that predicted risk of that patient having further hematoma growth. So if you're within the first kind of 3 hours, you're anywhere between 20 to 40% chance of growth, whereas once you get beyond 6 hours, you only have about a 10% chance of growth. So really, if we want to have an effect on hematoma growth, we really need to get the coagulation normalized or as soon as possible, and waiting several hours, and particularly if you're beyond 6 hours, the ship has sailed and you're not going to be providing much benefit. And this is one of the advantages of course, of having direct reversal agents that can immediately remove the anticoagulant effect and restore normal homeostasis. And just in simplistic terms, Andexanet alpha is a decoy molecule that binds factor Xa inhibitors, allowing the native factor Xa to engage in the normal physiology of the hemostatic cascade. And this is some data actually that one of our panelists, Deb Siegal, published in 2015 in New England, demonstrating that compared to placebo and Andexanet in apixaban treated patients can rapidly reduce anti-factor Xa activity almost down to 0 at the end of the bolus, and it's sustained until the end of the infusion, albeit there is a little bit of a rebound beyond 2 or 3 hours, but I'll show you the endogenous thrombin potential curves where despite this rebound, they're ability to form clot is maintained in a normal level once it is normalized through this process. And the figure on the right shows the same with rivaroxaban. And this is the ETP, or endogenous thrombin potential curves, demonstrating that at the end of the bolus, you get this immediate normalization of the ETP. And even though there is that little bit of rebound anti-factor Xa activity you saw in the previous curve, the ETP, or ability to form clot, is maintained within a pre-anticoagulant kind of range with either apixaban or rivaroxaban. And the first study that actually got a conditional approval for Andexanet alpha was a single-arm study of 352 individuals. Here, actually, the majority of patients were intracranial hemorrhage patients. 64% of the population had an intracranial hemorrhage on a factor Xa inhibitor, which is much more, for instance, than the idarucizumab study that did the same single-arm study for reversal of dabigatran. The indication for anticoagulation was 80% of the cases was AF, and patients would have had to have had an acute major bleeding event within 18 hours of their last dose, and they excluded patients with ICH volumes greater than 60 cc's and GCS less than 7, similar to what we did in the Annexa-I study that I'll describe in a second. And ultimately, the proportion of patients that had excellent or good hemostasis who've had an intracranial hemorrhage, I'm only showing the intracranial hemorrhage data here, was 80%. So about 20% of the population expanded, 80% did not. Of course, that seemed quite promising relative to historical controls, where I showed you there's a 40% expansion rate that would be expected. However, given the single-arm nature of the study, we weren't able to determine whether this was due to a treatment effect or really just because of selection bias in the population, being a population that's at lower risk than some of the other cohorts we've seen in the literature. And there was also this 10% thrombotic event rate. That's also seemed higher than what you would have expected and from the literature. But again, we couldn't tell whether this was just a high risk, frail, older prothrombotic population that was getting their anticoagulant reversed, and their intrinsic thrombin potential was being manifested as a result, or whether there was actually a treatment effect, and hence the need for the Annexa-I study, which is actually the only randomized trial of any direct reversal agent for DOACs ever conducted. And this targeted patients who were 18 years of age or older, who presented with an acute ICH within 6 hours symptom onset, and who were within 15 hours of their last factor Xa inhibitor dose. And this was a phase 4 multi-center prospective randomized open label blinded endpoint trial. And patients were randomized 1-to-1 to Andexanet versus usual care. The original sample size was 900 participants. However, at interim analysis, pre-specified interim analysis of 452 participants, the data monitoring board came back and indicated that the trial should be stopped early. And part of that decision was superior hemostatic efficacy with Andexanet alpha versus usual care. And it had to have been an overwhelming response for it to have had that effect to stop the study at only 452 participants. And hemostatic efficacy in this study was defined as meeting all of the following criteria rather. One, either a 35% proportional growth or less at 12 hours, an NIHSS score increase of less than 7 at 12 hours, and then no rescue therapy administration between 3 and 12 hours after randomization. Secondary efficacy endpoints included the percent change from baseline to nadir in anti-factor Xa activity during the first 2 hours post-randomization. And then there were select safety endpoints such as thrombotic events at 30 days and 30-day mortality. Baseline demographics were evenly distributed between the two arms of this study for the most part. As you'll see, this is a much older population that's having intracranial hemorrhages while on anticoagulants. The mean age is almost 80 years. There was adequate representation of females. Almost half of the population was female. And the average BMI was about 26. About 1 in 10 individuals had a prior history of myocardial infarction. 1 in 5 had a prior history of stroke. And 1 in 10 had DVT or PE, respectively. Atrial fibrillation was the indication in about 87% of the population. Congestive heart failure was present in about 1 in 5. Diabetes was present in a third of the population. And then the crank clearance was less than 30 mLs per minute, in about 5% of the population. Now, it is worth noting that there is some numerical differences in atrial fibrillation and diabetes, and I apologize for the misalignment with slide conversion. But essentially, there was a 5 to 10% excess risk of AFib and diabetes in Andexanet alpha arm, which who knows may have affected thrombotic events to some extent, but obviously it's not the whole picture. And then when we look at what factor Xa inhibitors patients were being treated with, 62, the majority were receiving apixaban, 28% were receiving rivaroxaban, and about 10% were receiving edoxaban. So more patients with edoxaban in this study relative to the Annexa-4 study as final population. And this really reflects basically the proportion of use of these agents in the market in the countries that the trial was being conducted within. And ICH was the primary location of bleeding in close to 90% of cases. Intraventricular hemorrhage was rare, as were subarachnoid bleeds, and subdurals were about 4 to 5% of the total population. It is worth noting that partway through the study, there was a protocol modification that excluded subdural and epidural and subarachnoid bleeds because of some concern about our ability to reliably measure volumes and growth in those compartments. So really, the majority of patients were parenchymal intraventricular hemorrhages. At that time, we also reduced the time from symptom onset to presentation or randomization from 12 hours down to 6 hours, given the importance of time for hematoma expansion. In 1 in 10 cases, the bleeding was preceded by trauma. Presenting systolic blood pressure was about 160, and then the mean presenting hematoma volume at their baseline scan was about 10 cc's. Mean GCS was 15. Baseline NIH stroke scale in terms of stroke severity was 9, which is about moderate disability. Time from symptom onset to baseline scan was 2.3 hours. Time from baseline scan to randomization was 1.1 hours. And then door-to-needle time was 2 hours. However, because this was, of course, in the context of a randomized study where you need to find either talk to the patient or get a surrogate decision maker to obtain consent, and then you had to go through the randomization process, we believe that this time from baseline scan to randomization could be almost eliminated in the real world. And actually, the door-to-needle time can actually come down more to about an hour. And perhaps with the improved door-to-needle times, we would predict that we would have even greater efficacy in the real world based on quicker treatment that no longer requires the randomization and consent process of a RCT. And hopefully in practice, we can actually achieve better times and better outcomes. In terms of the treatment received, 20% of the population received the high dose, 80% received a lower standard dose. And what is important, of course, for people, especially when they're trying to determine how relevant is our data to their current practice, is that the majority, about 86% of those assigned to usual care received PCC. And in those that we have data on the type of PCC they received, which is the majority of patients, 92% of them received 4-factor PCC. And I'll also mention that the mean dose of PCC was 3,000 units, which is, of course, often the max dose for PCC and many guidelines for factor Xa inhibitor reversal. And how generalizable are these results relative to what you would expect in hospital cohorts of patients presenting with ICH on DOACs? Well, actually pretty reasonably generalizable. So this is going back to some of the baseline demographics in that IPDMA by Savoulis and colleagues published in 2018 that I showed you earlier. And you'll see that the mean age is fairly similar. Proportion of female about half. AFib being the predominant indication for anticoagulation is also similar. ICH volumes are a little bit lower, but not dramatically so. So 13 cc's roughly in the IPDMA by Savoulis and colleagues, and only 10 cc's in Annexa-I. That is not surprising because we did exclude patients who presented with ICH volumes that were over 60 cc's. So our eligibility criteria mandated exclusion of very, very large hemorrhages that likely played into a lower mean. We also excluded patients with very low GCS that also did the same. However, our mean stroke severity quantified by NIH stroke scale was actually similar and numerically higher on 9 versus 7. So they're fairly generalizable to a target population. And the primary outcome of achieving effective hemostasis, that's occurred 13.4% more frequently in those assigned to Andexanet alpha versus usual care. And that's an absolute percentage. And this was primarily driven by actually excellent hemostat by the hematoma volume criteria, which was a proportional reduction of no greater than 35%, for every 100 patients treated, 12 individuals were more likely not to grow beyond this threshold. And although the data is not being shown here, most of these patients were actually had no more greater growth than 20%, which is a more conservative cutoff. There was also a numerical trend, but not statistically significant for NIH score, change of less than 7, being for every 5 in 5 individuals having less acute neurological deterioration if treated with Andexanet for every 100 patients treated, and statistically insignificant signals for rescue therapy and numerically going in the other direction. And then when we looked at the modified Rankin scale of 3 or less to define a good outcome at 30 days, there was no statistically significant difference between either arm of the study. But it's very important to note, one, that we were never powered to look at the MRS, not even when we initially had a sample size of 900, and definitely not so when we got stopped early, and ultimately we're left with 530 participants, and 452 was the interim analysis population that made the decision, but ultimately 530 got into the study. And also that we now know, and this is actually a fairly recent understanding in the pathophysiology of intracranial hemorrhage and ICH in particular, is that we need about 6 months of follow-up for the treatment effect of acute therapies in patients with intracranial hemorrhage to manifest themselves relative to comparator arms. So essentially all acute ICH studies are now implementing 6 or even 12-month follow-up outcomes. And it's only when we've gone out to 6 months that we've started seeing benefit in acute therapies for ICH. And 30 days is just way too premature to see a benefit. And there's actually been no acute stroke treatment that has shown a change in the MRS at 30 days that I'm aware of, even in ischemic stroke literature, yet alone ICH. So I don't think this MRS, the lack or neutral finding for MRS really can help inform our decision making just because of all the limitations it has. Now, to try to get around that, because as I mentioned earlier, a 12.5 cc cutoff of growth is well established in the literature to be a strong predictor of poor outcome at 90 days on the MRS. We did look at the effect of Andexanet alpha on this much more stringent cutoff of hematoma growth, which has very strong clinical relevance. And indeed, for every 100 patients treated, close to 6 were less likely to have 12.5 cc growth, and which is a very clinically relevant cutoff. Even more so than the original primary outcome. Now, why did we see these benefits with Andexanet alpha versus usual care, which is predominantly PCC? Well, for one, as we already knew from other studies, it's much more effective at reversing anti-factor Xa activity. And in Andexanet alpha arm, that was reduced by 95% at 2 hours versus about 27% reduction in the usual care arm. And actually, from previous healthy volunteer studies, we know this 27% reduction is essentially that you get with PCC is the same that you would get with saline or placebo. So that's just basically the natural history of clearance of the drug and the normalization of anti-factor Xa activity over time. Now, when we looked at different subgroups of patients, for the sake of time, I won't go list all of them, but you could read them. It was a fairly thorough look at different subgroups based on biological plausibility of treatment interactions. We did not find any treatment interactions that were statistically significant. It is worth noting that the benefits of Andexanet alpha in edoxaban treated patients was actually the same as those treated with rivaroxaban or apixaban when it came to achieving hemostatic efficacy, and actually numerically even greater, despite the fact that the anti-factor Xa decline was slightly less in edoxaban treated patients. And this is what's really compelling for me when thinking about the clinical implementation of this data and Andexanet alpha, when combining with some of the data we already knew, is that when you compare the effect of Andexanet alpha in patients who were destined to receive PCC as part of their usual care arm, and you compare the effects of Andexanet alpha versus those who not receive PCC, there's really no suggestion that those who receive PCC behaved any differently than those who received nothing as part of usual care. And if anything, numerically, the treatment effect was even greater in those that got PCC, but of course, it's likely a chance finding. And although this is not a perfect comparison, because there can be individual or subgroup differences that may be driving some of these observations. When you combine this with the fact that PCC has no effect on anti-factor Xa activity relative to saline, and this is a healthy volunteer study that I'm showing here on the left. You'll look at the effect on anti-factor Xa activity when patients getting Beriplex for factor PCC versus saline. As I mentioned earlier, the effect on anti-factor Xa activity is essentially the exact same. So really no effect on anti-factor Xa activity with PCC. Yet there does seem to be some factor Xa bypassing activity that does lead to earlier normalization of ETP or endogenous thrombin potential in those that receive Beriplex versus saline. But look at the time window, right? As opposed to what I had shown you earlier with Andexanet, where you get immediate normalization after the bolus and is sustained. Here, after the PCC is infused, it takes about 8 hours for that ETP to normalize. And so although there does seem to be some bypassing activity of factor Xa, and I'll just mention there just simply is not enough factor Xa in PCC for it to overcome the one-to-one stoichiometric inhibition that is provided by factor Xa inhibitors, right? So this is why we don't see anything on the figure on the left. It's just not biologically possible for it to reverse the effects based on the concentration of factor Xa in PCC. But whatever is causing this delayed normalization of ETP that's outperforming saline is occurring 8 hours later. And as I showed you in those graphs about the relationship between time and hematoma growth, in intracranial hemorrhage, that's just insufficient. It takes us back to the FFP days for warfarin, where patients' INRs were being normalized 5-6 hours later, like I showed you in that case from my training, and you saw what happens in that 5 hours, right? So this is not a sufficient of a rapid response that you need for an acute intracranial hemorrhage to reverse anticoagulation. And this is why, and this is just some data from the total data set that was published in Circulation of Annexa-I, again, demonstrating this rapid normalization of ETP and how it stays normal even after the infusion is stopped. This is why when I combine the biological plausibility of PCC providing benefit, the fact that the ETP, even though it does have some benefits over saline, it is so delayed at 8 hours. And I combine that with some of the signals we're seeing in our subgroup interaction that those that were destined to receive PCC behave no differently than those that receive nothing as part of usual care, makes me really question whether PCC is providing any benefit whatsoever in these patients. And for me now, it's no longer do I give Andexanet alpha or PCC in patients with intracranial hemorrhage who present within kind of a time frame that was eligible for Annexa-I. It's really become a question of do I provide Andexanet alpha or nothing at all. When we look at thrombotic events, the benefits of Andexanet alpha, and this is now in the total population of 527 participants, there was excess thrombotic events of 5 roughly for every 100 patients treated. And concerningly, these were actually ischemic strokes that are of greater clinical relevance than a DVT, for instance. And then when we looked at the outcome of mortality at 30 days, no difference in changes in mortality at 30 days. But again, the same limitations I described about lack of power and too early of assessment apply for mortality as well. And then when we looked at treatment interactions for thrombotic events, again, no statistically significant differences across the board at all. So the treatment response seemed to be consistent, although numerically there was a suggestion that perhaps in those that had a prior history of an arterial thrombotic event, that's where the majority of excess thrombotic events occurred with Andexanet alpha versus usual care. And if you exclude patients, and this was the majority of the population who did not have a prior history of an arterial thrombotic event, the risk of excess thrombotic events with Andexanet versus usual care was minimized. And this may be a triaging tool and has good biological plausibility, of course, to implement, even though subgroup analyses can be non-conclusive. And of course, in that case, the p-value for the interaction was negative. We now have, of course, a scenario where we have a very clear benefit, but also a lower risk of harm. So if you remember, again, for every 100 patients treated, 13% were less likely to not achieve hemostatic efficacy. And then for every 100 patients treated, there was 5 excess thrombotic events. So your number needed to treat is more than double the number needed to harm. But still, we want to find tools on how to maximize that net benefit and even increase it further. And this was the purpose of this secondary analysis that we presented at the International Stroke Congress in February. And here we were looking at predictors of hematoma expansion and response to treatment to Andexanet alpha, hoping that we could identify subgroups that have greater net benefit. And our primary outcome here was actually a more conservative definition of hematoma expansion by an increase in hematoma volume of 12.5 cc's or 35% based on brain imaging between baseline and 12 hours. And I mentioned these cutoffs have positive predictive values of 80% and 70% respectively for poor outcome on the MRS at 90 days. And we looked at all the total population set of 530% participants, but excluded patients who had missing baseline or follow-up imaging and also non-intracerebral hemorrhage bleeds. And overall, we were left with 459 participants. And we looked at the prediction or models for hematoma expansion in 2 ways. In addition to adjustment for treatment assignment, the first model adjusted for ICH volume, degree of anticoagulation based on baseline anti-factor Xa levels, and then time from symptom onset to treatment, and then a model 2 pre-scan hematoma growth rate based on which is a measure that basically you divide the volume of the initial scan by the time from baseline symptom onsets to that scan. I'll talk about that a little bit further. And in model 1, we found that apart from assignment to Andexanet, which reduced, of course, the risk of hematoma expansion, patients who presented earlier from symptom onset were more likely to expand, consistent with the literature on ICH. Although anti-factor Xa activity did have a robust effect size of 1.20 and was statistically significant univariate analysis, although the effect size didn't change, it did lose statistical significance in the multivariable model. And we suspect some of that may be collinearity between the degree of anticoagulation and the presenting hematoma volume, which was seemed to have been more robust, at least in terms of statistical significance, predictor of expansion. The greater the volume, the more likely the patient was to expand. And then ultimately, when we also looked at the pre-scan hematoma growth rate, there was a positive association between the faster that hematoma was growing by the time they had their baseline scan and the risk of future growth. Now, in these 2 figures, we're demonstrating the risks of hematoma expansion on the y-axis relative to baseline hematoma volume on the x-axis on the left, and time from symptom onset to treatment on the right. As you can see that they're across the range of these metrics, the higher the baseline hematoma volume or the earlier someone presents from symptom onset, the greater the risk of expansion, and that the effect of Andexanet in red relative to the usual care in blue is fairly consistent proportionally across the range of these metrics, except at the very extreme where we have few data points and you get overlapping confidence intervals. We saw a similar pattern in pre-scan hematoma growth rate. Again, a positive correlation throughout the range of the metric, and the proportional reduction with Andexanet in red is constant relative to usual care in blue. But again, when you have very few data points and dots towards the right of the figure, you have more overlapping of the confidence intervals. So what does this mean? Well, for instance, when you look at the usual care arm, amongst all comers, the hematoma expansion rate was 40%. However, when you break it down based on quartiles of these metrics, so for baseline ICH volume, people who are presenting within the first quartile of less than 3.5 mils, their risk of expansion is about 28%, and it goes as high as 54% if they're presenting with volumes of 22 cc's or greater. Conversely, if you present with the short time from symptom onset to treatment, your risk of expansion is quite high at 50%, and it goes down with greater time, and it goes down to 25% with presenting the 4th quartile of 5.4 hours from symptom onset or greater. For pre-scan hematoma growth rate, if you're in the first quartile of less than 1.2 mLs per hour, your risk of expansion is 20%, and it increases as high as 60% when you reach the fourth quartile, which is 11.4 mLs per hour or greater. And particularly in the case of baseline ICH volume and pre-scan hematoma growth rate, your absolute benefit is also increasing from about 14 per 100 patients treated to 26 in those in the fourth quartile of baseline hematoma volume, and 25 in those that have the fourth quartile pre-scan hematoma growth rate. And overall, there was no relationship whatsoever with these metrics and thrombotic event rates, which in patients with just ICH, there was 4 excess thrombotic events for 100 patients treated. But again, they were not increased with these metrics. So by choosing patients that are higher risk of expansion through these metrics, you're maximizing the risk of expansion and treatment effect, and while maintaining the same level of thrombotic risk. And I'll just mention that although patients that have the higher risk within these quartiles are at very high risk of 50 to 60%, the risk of expansion at the lowest quartiles or lowest risk quartiles are not negligible. They're somewhere between 20 to 25%, so 1 in 5 or 1 in 4. So I don't want people walking away from this and saying that if people present very within the lower risk categories of these quartiles, that their risk is negligible, but certainly much less than those that present at the higher rates. And this is reflected when you look at the number needed to treat, and in this instance, for instance, with hematoma expansion, for the pre-scan hematoma growth rate, you'll see that the number needed to treat to prevent hematoma expansion is quite robust across the board, right? It's all less than 10, irrespective of the quartile. It's only further magnified and amplified to a number needed to treat of 4, a much stronger treatment effect in those that reach the highest quartile of hematoma growth. And by comparison, the number needed to harm for a thrombotic event is about 25 in the sample. And how do we bring this kind of all together in a clinical sense? Well, we provide 2 cases. The first is that of a 75-year-old woman who's got atrial fibrillation on apixaban, presenting with a left pentaminal ICH, and their baseline ICH volume was 24 cc's. They presented 2 hours following symptom onset. So their pre-scan hematoma growth rate can be easily calculated by dividing the 12 cc's as 12 cc's per hour, and that's by dividing 24 divided by 2. So 24 cc's divided by 2 becomes 12 cc's per hour. And their risk of expansion is 60%. The number needed to treat with Andexanet to prevent expansion in this scenario is 4. And number needed to harm to cause a thrombotic event is about 26. So this is a fairly slam dunk case in my view. The case 2 is an 81-year-old man with a remote history of unprovoked DVT on rivaroxaban, presenting with right thalamic ICH. They're presenting with a small bleed late, so a 6 cc hemorrhage within 5 hours following symptom onset. So their pre-scan hematoma growth rate is calculated by dividing 5.9 by 5 hours. So you get 1.18 mLs per hour. They're in the lowest quartile of growth. Risk of expansion is not negligible, however, 20%. Number you treat with Andexanet to prevent expansion is higher at 8. Number you need to harm is maintained at about 26. This is a case where there's less benefit than the first case. And on the basis of their prior thrombotic event, and based on some of the data I showed you, that will then push me to not treat this individual because the overall benefit is attenuated and they're at high risk of a thrombotic event on DVT. But had this patient never had a prior thrombotic event, based on the 1 in 5 risk of expansion and number needed to treat of 8, I would still definitely consider it. Now, this is a preliminary figure that I've kind of put together to try to put this in a more visual format. So in patients with factor Xa inhibitor ICH who meet trial criteria, so volumes less than 60 cc's, time from ICH onset to presentation less than 6 hours, time from last dose of factor Xa inhibitor less than 15 hours, you can basically put them into a high, intermediate, or low risk category based on their pre-scan hematoma growth rate. There's corresponding risk of hematoma expansion, number needed to treat to reduce hematoma expansion, and enthusiasm for treatment are listed. And then when you end up in an intermediate or low category, that's really when you take other information into account. For instance, I didn't show this data, but elevated blood pressure is also a predictor of hematoma expansion. So if someone had elevated blood pressure and a high pre-ICH function, that would increase one's enthusiasm for treatment, even in the intermediate and low categories, while a prior history of a thrombotic event or low pre-ICH function would then reduce their enthusiasm. It's fairly easy to calculate the pre-scan hematoma growth rate if you have the volume. However, if for whatever the recent instance, you don't have a good idea of hematoma volume, you still need it in a ballpark, and this is a more pragmatic approach, and these cutoffs are very arbitrary, but I'm just trying to provide a more quick and dirty approach where you're trying to essentially determine whether someone's a large or small bleed presenting early or late. If they're large and early, they're at the high risk. If they're either small and early or large and late, they're in this intermediate category. And if they're small and late, then they're in the lower risk category. And then the large versus small cutoff is set at 10 cc's rather arbitrarily. And the early versus late is set at 4.5 hours or earlier or versus greater than 4.5 hours. Again, keeping in mind that patients with greater than 6 hours from symptom onset or those with 60 cc's or greater were excluded from the study. So to conclude, Annexa-I is the only RCT of a direct reversal agent versus usual care in DOAC-associated intracranial hemorrhage. Andexanet led to significant higher hemostatic efficacy, but the benefit was partially offset by excess thrombotic events. The benefit of PCC in factor Xa associated intracranial hemorrhage is questionable, and I'm actually a non-believer of its effect in intracranial hemorrhages based on the timing of the normalization of ETP, as we mentioned. Individualized treatment decisions can help maximize net benefit from Andexanet. So I'll end there and open it up to Q&A and a panel discussion.
Thank you, Ashkan. That was an amazing presentation, and I think it's great for all of us to see this data. We've sort of been eagerly awaiting it ever since the announcement that the DSMB was shutting it down early. And so there are a lot of questions, and I'm going to sort of present them in a format with questions about the trial, questions about interpreting some of the results, particularly thrombosis and lab data, and then sort of the pragmatic implementation. How do we approach this? Because there are a lot of questions, as you could imagine. And I will say in Truth in Advertising, I was a co-investigator here at our site for Annexa-IV. Danny Palin was one of the co-authors on the authorship for the New England Journal paper. So I have maybe a slanted view, and we've certainly set up a culture for use here. And I want Jerrold and Deb to chime in, as well as Jori, because I think this is an area of hot debate. And I think lots of differing opinions around the world. And so I think learning from all of us and our different perspectives is going to be important. One of the first questions that has come up in many areas since the dissemination of the information, and even in our open chat, in our pre-registration questions, is the use of the standard of care arm or usual care. And there are two questions. From a trialist perspective, why not dictate PCC? And then from the end users, we do have a lot of questions about, okay, you showed us the breakdown of the 87% who got PCC and the types of PCC, but what about those 13%? What did they get? To me, it looks like it didn't matter, but it'd be interesting to know how other institutions approach that. So, Ashkan, you can go first.
So
and we'll have Deb and Jerrold and Jori chime in.
Yeah, no, it's a good question. So, actually, the majority of people who were not destined to receive PCC as part of usual care received nothing at all. There was a smattering of TXA and other agents, but the majority received nothing at all. And interestingly, part way through the study, we actually had very little PCC use. To the point that we actually had to make an appeal to our investigators to say the guidelines are that really PCC should be used. It would be a shame if we finished a study with very few PCCs in the usual care arm. And then over time, as the guidelines got published, more data came out, observational data that wasn't really the most reliable data, but still suggested a benefit of PCC. There was an uptake, and it was being used more frequently. Unfortunately, we were left with a large population that got it at the end. And why not dictate one standard of care? Because there isn't one standard of care globally, and this was a global international study, probably Europe and North America, but it was a international multi-center trial, and that there was a lot of variability in practice. And even, for instance, I know my colleague Josh Goldstein, who's a emergency room physician at MGH, but also very heavily involved in acute ICH research. He says that MGH don't ever use PCC, and is basically giving Andexanet or nothing. That's been their practice even before the Annexa-I data, and that's based on the some of the assays that we talked about and their effects, the subpar effects of PCC in that setting. Certainly there's a lot of people around the world who did not feel that there was sufficient data to give PCC even at all. And that was the more common scenario in the usual care arm if someone was not receiving PCC.
Deb or Jerrold, Jori, any comments to that?
Can I make a comment? Thank you, Dr. Connors. So great discussion. Just a few, I think, perspectives. This is a small volume bleed of 10 mils. Clearly, the Andexanet story makes a lot of sense. First, the data you showed, Marcel Levy's study in 2014 in thrombin generation, I'm a co-author on that. Those dosing of rivaroxaban was 20 milligrams twice a day. So the levels are too high to be reversed. Furthermore, I did a study where we actually did 100 volunteers with 20 twice a day. And the bleeding times, basically, it takes a while to normalize to less than 75 nanograms per mil. Jimin Liu's data with Pam Conley showed that. You have to have a lower level for it to work. But the small volume bleed, like you've shown, is really totally different than the patient comes in, major surgery, post-trauma, where you're treating like not only the anticoagulant, but you're treating a hemorrhagic effect with need for factor replacement. I think the ICH really is clearly shown, and obviously 64% of the original Annexa study, as well as your study. And I think your data is really important. Bravo and kudos to you and the team. But just, again, be careful extrapolating the ICH data to the rest of the data. And that's being done in some clinical practices. It's a different bleed. And again, thanks for that superb presentation. But a few caveats to consider. Thank you.
No, and I agree with you 100%. And if you notice, I was fairly careful in my wording in that every time I said I don't think it's beneficial on ICH.
Of course. I'm saying that. I agree.
Because I think in certain circumstances, as you've outlined, where it's okay to reverse it a bit later, and then that's fine. But in a setting that where every minute counts in terms of hematoma growth, then I don't think the PCC effect is sufficient.
And it's a closed space bleed, which is also even a more critical phenomenon. Again, great presentation. Thank you.
Thank you. Yeah.
Yeah, no, I think this still raises the important question about in whom to use it, right? And we're going to get to that at the end. But more, when we look at your study criteria, our ED is our radiologists are pretty good at documenting hematoma volume. I am struck by standard of care not doing anything, which is again sort of different from our current culture, because we've used Andexanet now for over almost 6 years, 5 years. So I think that I was interested in your last slide about not using it in people with very small initial presentation and low risk for progression. Can you elaborate more on that? I mean, do you really?
Yeah.
This is going to lead into Deb, Jerrold, and Jori about the thrombotic risk.
Yeah. So there's a distinction between small and early is still a concern. Small and late is less concerning, right? And so people who are presenting with small bleeds after, let's say, 5 hours, that person has already shown that they're not going to be a fast grower, and their rate of expansion is much less. So all comers, the rate of expansion in the control arm is 40%. In those that are presenting with small bleeds late, with that fourth quartile of hematoma growth rate, they only had a 20% risk of expansion. Now, one only is relative, a 1 in 5 chance of expansion that can have really poor outcomes. But certainly different than, for instance, the highest growth rates that were large early bleeds, which had a 60% risk of expansion, right? Which was just quite dramatic. But so early, small early, still intermediate risk, and that's about going to be a 40% risk of expansion. And again, remember, the number near tree is going to be less than 10 across the board, even in the small late bleeds. But since their absolute rate of expansion is about 20%, if they have other risk factors for thrombotic events, or if they're already a pre-morbid, frail patient who has poor has some disability, pre-existing disability already, the benefit may be attenuated quite a bit in that setting, and you may want to then avoid treatment.
So I think this is a critical point that I would love to have us all discuss, because not having seen prior to your slides the types of thrombosis, I was imagining DVTs, line-associated clots, which are, you know, in the whole scheme of life, insignificant. Do you have any data about time course of when these events happened? You know, did you reverse and then the next day they had another, you know, stroke, another thrombotic stroke, or were they delayed? I know Deb has done work on when you reinitiate anticoagulation, right? These are people who had an ICH, but they're on anticoagulation for a variety of reasons, particularly the high AFib population, right? So when we look at, I don't know if you looked at Chad's VAS scores in your population in the AFib group to see what their risks were, but I think it's a critical point about, you know, causing thrombosis. And then I'm going to ask Jerrold and Deb and Jori to weigh in on what are the mechanisms, but time course and
yeah, so the time course
AFib stroke risk, yeah,
actually early. So within the first 5 days was the majority of excess thrombotic events. So, and I won't steal Deb and others' thunders about why we think that might be, but certainly there is a treatment effect that's driving this excess risk, and I look forward to the panel discussion about what the potential causes may be.
Deb.
Yeah, you know, I think it will be, we've all kind of been waiting. Thanks so much, Ashkan. That was like a great presentation. And I always want to just, you know, I know we have only a few minutes left, but just to highlight the importance of really understanding the population under study. And when we're thinking about the Annexa-I data, thinking about the trial and, you know, what it shows and then what some of the limitations are, which I think you've nicely identified. The thrombotic risk is after treatment is an important concern for people, because of course now we have this additional equipoise, right? About we've seen some benefit for sure compared to usual care, and then we've also seen an increased some increase in harm. And so identifying who those people are that may benefit maximally, I think would be really important. So there's, you know, obviously these issues of, you know, when did people restart anticoagulant therapy? I know Ashkan has led the ENRICH trial, and so that's a trial looking at restarting anticoagulation after intracerebral hemorrhage for people on AFib. So you're also well aware of this as a concern. So, you know, certainly if there was information about whether or when people started some type of antithrombotic post-bleed, I imagine within 5 days that might not have been the case, but it will be helpful for us to understand that, I think, going forward, looking at the publication. There is a mechanism, of course, of increased ETP or endogenous thrombin potential, which could relate to the thrombotic events. And then, you know, thinking about the mechanism of Andexanet and binding to TFPI as a mechanism for increased thrombosis is a possibility. So I think those are important. To me, the issue here is how do we apply these results? You know, not that these results, you know, clearly there's a lot of value in the study, and I can only say that I have an appreciation for how difficult these types of trials are to do, and how important this type of data are for us and our patients. So yes, it's helpful obviously to be critical, but also to understand how we can use these results to help people.
Yeah, no, Deb, I think that's a great point, because I think there are two important points, Ashkan, about these data. One is that they are the first randomized controlled trial of anything in stroke. Prior to this, we had standard of care, which varied significantly. And what we're learning, I was very encouraged to hear you say that 30-day outcomes are not maybe the endpoint that we need to look at when we're looking at efficacy, functional efficacy, right? Because I used to say when we were, speaking locally that, intuitively it makes sense to stop bleeding, right? And that the smaller territory of bleed, the better off you may do. But you've already sustained damage, right? You've already had a bleed that's impaired function. And so recovering from that is a lot more subjective, even though we have like the modified Rankin and the NISS stroke score. There's still a little wiggle room in there for how we capture that. So
Can I just ask a quick question, Jean?
I'll
Sorry,
just maybe add a very quick insight about ICH in particular, because that hematoma is going to be constantly leaching iron media toxicity into the brain.
Yep.
As macrophages go on to clean up that hematoma, they're going to be releasing free radicals and reactive oxygen species and so forth, and causing a perpetual inflammatory process in the brain until that hematoma is completely resolved. And this is one of the reasons the recovery trajectories in ICH patients in particular are much longer than ischemic strokes, and it's even more important to wait longer to see benefit of treatments in ICH patients.
Can I just make one other comment? When you're bleeding into the brain, that all that hemoglobin scavenges nitric oxide and is a major contributor to spasm. I actually had a spasm model that we looked at, and free hemoglobin is not bueno in this situation. The other point, just a quick comment, the thrombin generation data you showed is really important. If you're bleeding, you got to generate thrombin. If you don't generate thrombin, you're not going to clot. And if you don't clot, you're going to stop bleeding. So it's really important to have that thrombin surge. But as Deb points out, the idea is that, it continues on, and you don't see that with PCC. So my lab did a bunch of thrombin generations over the years. So really important, and finding that equilibrium. But again, close space bleeding is really critical to shut off. And the thrombin generation data that you show is also important when the levels are going down. Thrombin generation stays, normalized. So that's extremely important, because when you first see the data, it's disconcerting. Furthermore, in Deb's study with the rivaroxaban, which is twice as high the concentration, you overshoot beyond the control. You probably sequestered it from metabolism. So this thrombin generation data is really important for efficacy. So a few comments. Thank you.
And that was one of the, oh no, Deb, I think you had a follow-along question.
No, actually, I was just going to ask in following up, just because of the more long-term functional outcomes, are there going to be follow-up data? Do you know about that? Not as part of the trial necessarily, perhaps as a follow-up study, just to categorize that or characterize that.
Excellent question. I totally agree. We're looking for that data, not to put you on the spot.
Or another trial, Ashkan.
You're preaching to the converted.
Yeah, I know.
Regard.
I know.
But it's easier said than done, unfortunately, because we'll need to reestablish REBs at all the sites, and many patients have already passed 6 months of follow-up, and it's actually in practice it's a lot messier to implement, and that has reduced enthusiasm among some people.
Okay, I think we could go on for another half an hour. Unfortunately, we are running out of time, and so I would like to thank our speakers. Ashkan, an outstanding presentation. Thank you. Deb, Jerrold, outstanding contributions. Jori, outstanding contribution. I know we did not address all of the questions. The last comment for you, Ashkan, is what do you do in your institution, and what would you recommend today? Andexanet or FRCPC?
Short answer is Andexanet for ICH patients, definitely. The long answer is we're still trying to get funding in Canada for the drug.
Thank you. Talk to us. We have a door time of less than an hour, 30 minutes to get the drug mixed and ready, and then all the kerfuffle of making sure the line works and all of that. So with that, more to follow. We're looking forward to hearing more from you, Ashkan. And I want to alert all of our listeners first, thank you, and watchers today to this webinar. Thank you for joining us for the AC Forum. webinar series. Our next webinar will be on Wednesday, May 29th at same time, which May is Women's Health Month. And so along those lines, we are giving a webinar on women's health considerations in thrombosis with outstanding moderators Naomi Yates and Sarah Vasquez and Bethany Samuelson Bano from Oregon Health Sciences University, and our own AC Forum member Jori May as panelists to discuss considerations in thrombosis for women. So thank you. We hope to see you at that time. Our next announcement is just 2 weeks away. We have Anticoagulation Boot Camp. I recommend this highly. My staff have attended both in person and virtually in my anticoagulation management services and walk away raving about the AC Forum Boot Camp. It is a very hands-on, pragmatic experience. And then finally, next year, all of you listeners and watchers, we expect to see you in person to hear more information about anticoagulation, thrombosis, and its management at our national meeting for the AC Forum in April 2025. Again, Washington, D.C., our next AC Forum national meeting. Thank you, everyone. I want to thank Ashkan and our panelists. Thank you.
Goodbye.